Across the world, childbirth is changing. Not slowly, not naturally, but rapidly, and in many places, unnaturally. For the first time in human history, surgical births are rising faster than complicated pregnancies. Hospitals are performing more C-sections than ever before, and the increase is so sharp, so widespread, and so unequal that global health experts call it the silent surgical epidemic. This is the story of how C-sections became a global business, how vulnerable mothers are being pushed into operations they may not need, how countries across Asia, the Middle East, the Americas, Europe and Africa are all facing their own version of the crisis, and what every family must know before stepping into a hospital. In this video, we uncover the global explosion of C-sections. We explore why surgical births are increasing far beyond medical need, how fear, convenience and hidden business pressures are influencing one of the most intimate moments of a woman's life, and how mothers across continents are sharing the same stories of pressure, panic and rushed decisions. We dive deep into real incidents from around the world. We uncover the long-term impact of unnecessary C-sections on mothers. We examine how surgical birth affects babies in ways most parents are never told. And finally, we discuss what every mother, father and family must know to protect their birth experience, no matter where they live. This is not a message against C-sections. This is a message for informed choice, for transparency, and for a safer future for mothers and babies worldwide. Welcome to a conversation that every family deserves to hear. The global explosion of C-sections. For decades, the World Health Organization recommended that 10 to 15% of births should be via C-section, enough to save lives, but not high enough to encourage unnecessary surgeries. Today, more than 80 countries exceed that number. In Brazil, especially in private hospitals, the C-section rate is above 80 to 90%. Nearly every baby is delivered surgically. In China, rates shot up after the one-child era, with some cities crossing 45 to 60%. In India, private hospital rates range from 50% to 80%, much higher than public hospitals. In Pakistan and Bangladesh, urban private hospitals show similar numbers. In Vietnam, elective C-sections doubled within a decade. In the Gulf countries like Saudi Arabia, Kuwait and UAE, C-sections are often marketed as luxury painless deliveries. In the United States, 1 in 3 births ends in surgery. In parts of Europe, such as Italy and Cyprus, rates have climbed far beyond the safe limit. In Africa, there is a strange double curve, extremely low C-section access in rural regions and extremely high rates in private urban areas. Different countries, different cultures, same pattern. A surgical procedure meant for emergencies has become a routine operation. According to the World Health Organization, the world is witnessing one of the fastest growing medical shifts in human history, the rise of C-sections. In 1990, the global C-section rate was just 7%. Today it has tripled to nearly 21%. And the WHO now predicts that by 2030, the number may reach 29%, meaning almost 1 out of every 3 births worldwide will be surgical. The WHO also reports that more than 100 countries now exceed safe C-section levels by a large margin. In Asia, rates have nearly doubled in just 2 decades. In parts of South America, especially Brazil, the levels are among the highest ever recorded. In many high-income countries, the WHO warns that birth has become over-medicalized, with C-sections performed for convenience rather than medical need. The trend is particularly steep in India, where national data shows C-sections rising from 17.2% in 2016 to 21.5% in 2021, an increase of nearly 25% in just 5 years. But the most dramatic rise is in private hospitals, where rates increased from 43.1% to 49.7% within the same period, approaching levels seen in Brazil and China. The WHO highlights that many countries with extremely high C-section rates are not experiencing proportionate increases in complicated pregnancies. Instead, they are experiencing a rise driven by commercial pressures, institutional practices, and systemic incentives. Their message is sharp and clear. The rise in C-sections worldwide is not explained by medical need. C-sections should only be performed when necessary, not for convenience, scheduling, or financial incentives. The WHO warns that unnecessary C-sections increase risks for mothers, raise complications for future pregnancies, and create long-term health challenges for babies. And the trend, if uncorrected, could become one of the biggest maternal health crises of the next decade. Why the world is shifting to surgical birth, the business behind it. This rise is not driven entirely by medical necessity. It is driven by systems, incentives, workload, economics, and fear. 1. Economic incentive. A natural birth may take 10 to 20 hours. A C-section takes 30 to 45 minutes. Surgery can be billed higher, sometimes 3 to 5 times more. Hospitals profit. Doctors save time. Beds open faster. Schedules stay predictable. This formula repeats from Delhi to Dubai, from São Paulo to Beijing, from Los Angeles to Lahore. 2. Legal pressure on doctors. In countries like the US, China, India, and Brazil, doctors face lawsuits if something goes wrong during a natural birth. C-section becomes the safe choice for the hospital, not always for the mother. 3. Fear-based communication. Across Asia, India, Pakistan, Bangladesh, China, Vietnam, the same sentences are heard in labor rooms. Heartbeat is dropping. Your cervix is not opening. Your pelvis is too small. Baby is tired. Liquor is less. Don't risk the baby's life. Some cases are real emergencies, but many are pressure tactics used at the weakest moment of a mother's life. 4. Scheduling convenience. Natural births can come at 10 p.m. or 10 a.m. C-sections can be done before lunch. Hospitals prefer control. 5. Cultural and social pressures. In Brazil and China, C-sections became signs of status and modernity. In the Gulf, elective surgeries are marketed as premium experiences. In some cultures, parents choose specific auspicious dates, and that requires scheduling. 6. Lack of midwives. Countries with strong midwife systems, like the Netherlands and Sweden, have the world's lowest unnecessary C-sections. Most Asian and American hospitals depend almost entirely on obstetricians. This combination creates a global environment where fear meets profit and the mother's voice gets lost. Real stories from across the world. These stories are not rare, they represent millions. India, the case that shocked families. In 2023, a 26-year-old first-time mother from Telangana, let's call her Radhika, arrived at a private hospital during early labor. Her pregnancy scans were normal. Within 1 hour, her family was told, heartbeat dropping, emergency, sign now. She was rushed into surgery. Later, when her husband requested the CTG trace, the file showed no emergency dip. Local authorities later discovered the hospital had a 78% C-section rate that month. Families in India, Pakistan, and Bangladesh report hearing identical pressure lines, almost like a script. Pakistan, a mother in Lahore shared that nurses repeatedly said, "Your baby is getting tired," though CTG strips later showed stable heartbeat. Only later she discovered the doctor had 3 surgeries scheduled. Bangladesh. A Dhaka-based NGO reported that hospitals told women their pelvis was not suitable for normal birth, often without any physical examination. China, a woman in Beijing was advised, surgery is safer, natural birth damages the body. Her doctor performed 7 C-sections in that single afternoon. Vietnam researchers found the same justification used by multiple hospitals. Your pelvis is too small, even for women with average measurements. Brazil Maria, a 29-year-old from São Paulo, was told she was late for labor and immediately taken for surgery. Her records later revealed no emergency indicators. Gulf countries, UAE, Kuwait, Saudi Arabia. Private hospitals advertise C-sections as painless premium packages. Mothers often book their delivery the way people book a hotel stay. United States. A Texas mother was told, "Your baby is too big for natural birth." The baby weighed just 2.8 kilograms, perfectly normal. Later, she discovered her hospital offered incentives for C-section numbers. Europe, in Italy and Cyprus, women report that doctors routinely suggest surgery to avoid prolonged labor. Africa, urban private hospitals in Kenya and Nigeria show C-section rates above 60%, while rural women struggle to access surgery when it's actually needed. Different continents, same pressure, same panic, same silence. Long-term impact on mothers. A C-section is not a small surgery. It is one of the largest abdominal surgeries in modern medicine, cutting through skin, fat, fascia, abdominal muscle layers, peritoneum, the uterus, and the amniotic sac. When done unnecessarily, the impact on a mother's body can be long-term and sometimes lifelong. Let's go deep into what actually happens. 1. Physical recovery. Slow, painful, and often underestimated. After a vaginal birth, many women walk within hours. After a C-section, mothers face difficulty getting out of bed, severe incision pain, inability to lift the baby, trouble turning, laughing, or coughing, longer hospital stays, 3 to 6 weeks of restricted mobility, prolonged swelling, and internal soreness. In many Asian countries where mothers return to household chores within days, the recovery becomes even harder. The key issue? Most families underestimate the seriousness of the surgery. 2. Internal scar tissue, adhesions. The silent complication. C-sections create scar tissue inside the body. This scar tissue, one called adhesions, can stick organs together, twist the intestines, cause chronic pelvic pain, create digestive issues, lead to painful periods, make future surgeries risky. Adhesions often appear months or years later, so mothers don't even connect their pain to the C-section. Some women require additional surgery just to remove adhesions caused by the first surgery. 3. Increased complications in future pregnancies. A mother who has one C-section faces higher risks in future pregnancies. Placenta previa. The placenta sits low and blocks the cervix. Placenta accreta. The placenta grows too deeply into the uterus and is life-threatening. Placenta percreta. The placenta grows through the uterus into other organs. These risks increase with every additional C-section. In countries like India, Pakistan, China, Brazil, and the Gulf, repeat C-sections are rapidly rising, increasing life-threatening complications in the future. 4. Risk of emergency complications, hemorrhage and infection. Because a C-section is a major operation, the risk of postpartum hemorrhage, severe infection, blood clots, anesthesia reactions, wound breakdown, long-term nerve pain is significantly higher compared to a natural birth. Infections are particularly common in hot and humid climates, such as those found in South Asia and the Middle East. 5. Emotional and psychological trauma. This is extremely under-discussed. Many mothers report feeling robbed of a natural birth, feeling they failed, feeling rushed into surgery, loss of control during labor, fear that they almost lost the baby, based on pressured statements, sudden panic during surgery, postnatal depression from the shock of unexpected surgery, difficulty bonding with the baby due to physical pain. In countries with high-pressure hospital environments, mothers often describe the C-section experience as, "I wasn't given time. I felt forced. They scared me. I couldn't fight back." This psychological impact can last for years. 6. Impact on breastfeeding. C-sections can delay the first latch, milk production, skin-to-skin contact, mother-baby bonding. Anesthesia and exhaustion reduce the baby's suckling reflex in the first hours, which affects long-term breastfeeding success. Many mothers worldwide say, "My milk didn't come in for 3 days after the C-section." This is common. 7. Long-term pelvic and core weakness. Because muscles are cut or stretched, core strength drops, posture weakens, back pain becomes common, pelvic floor muscles become imbalanced. Some experience urinary incontinence. These problems may appear 6 months or even 5 years later. Impact on babies. A baby's physiology is designed for natural birth. During labor, the baby receives signals, hormonal, physical, and neurological, that prepare the body for life outside. When the baby is delivered by C-section, especially elective or unnecessary ones, several important processes are bypassed. Let's go deeper. 1. Breathing difficulties. During a vaginal birth, the baby's lungs are naturally compressed as they pass through the birth canal, pushing out excess fluid. In a C-section, lungs may still contain fluid, breathing may be labored, oxygen saturation may drop, the baby may need NICU support. This is why C-section babies have higher rates of transient tachypnea, respiratory distress syndrome, especially babies born before 39 weeks of gestation. 2. Missing the microbiome transfer. In natural birth, the baby is exposed to beneficial bacteria from the mother's birth canal. These bacteria start shaping the baby's immune system, reduce allergies, reduce autoimmune disorders, support digestion, strengthen long-term immunity. In C-section births, babies miss this exposure and instead receive bacteria from the operating room environment. This is linked to increased risks of asthma, eczema, food allergies, obesity, Type 1 diabetes, digestive issues. This difference is not harmful in every case, but the trend is globally consistent. 3. Lower stress hormone preparation. During natural labor, the baby experiences stress hormones, adrenaline, cortisol, that help prepare the lungs, increase alertness, mobilize energy, help the baby adapt to cold air, support early feeding. C-sections interrupt this hormonal cascade. This is why C-section babies often appear sleepier, cry later, take longer to latch, struggle with early feeding, take more time to adapt. 4. Impact on bonding. Skin-to-skin contact within the first minutes is crucial for emotional bonding, regulation of heart rate, temperature stability, breastfeeding success, calming the baby. In C-sections, especially in high-pressure hospitals, mothers and babies may be separated for suturing, anesthesia recovery, routine observations, staff convenience. This delays essential bonding time. 5. Long-term health trends, global data. Population-level studies report that babies born by C-section may have higher chances of childhood obesity, childhood asthma, metabolic disorders, autoimmune conditions. These are associations, not guaranteed outcomes, but the data is repeated across India, Pakistan, Bangladesh, China, Brazil, USA, Europe, meaning the pattern is not cultural, it is biological. 6. Impact on baby's gut health. Gut bacteria determine immunity, digestion, metabolism, inflammation levels, even mood via the gut-brain axis. C-section babies often develop different gut flora, slower colonization of good bacteria, higher levels of harmful bacteria. This can affect their health for years. Again, C-sections are life-saving when needed. The danger lies in unnecessary surgery. What mothers can do. Globally applicable guidelines. In every country, whether it's India, Pakistan, Bangladesh, China, Vietnam, Brazil, the Gulf, the United States, or Europe, mothers often feel that childbirth is something that happens to them. But the truth is this: birth is not a passive event. It is a decision-making process, and mothers have more power than they realize. Here are globally applicable steps every mother and family can take, regardless of hospital, country, or culture. 1. Ask about the hospital's C-section rate before you register. This single question reveals more than any marketing brochure ever will. Ask directly, what is your hospital's C-section rate? Here's how to interpret it. Under 20%, balanced and normal. 20 to 40%, moderately high but acceptable depending on population. 40 to 60%, high, expect pressure. Above 60%, you must be cautious. Above 70 to 80%, this is a red flag for unnecessary C-sections. Hospitals with extremely high rates tend to follow a predictable pattern of fear-based communication. A mother who knows her hospital rate is already more protected than a mother who walks in unaware. 2. Create a birth plan. Even if you are delivering in a private hospital. A birth plan is not a demand. It is a communication tool that removes confusion in the delivery room. Your plan should include preference for natural labor progression, movement during labor, freedom to walk, squat or change positions, delayed admission unless medically necessary, intermittent fetal monitoring instead of continuous monitoring, avoiding artificial induction unless medically required, presence of a birth companion, permission to labor longer before choosing surgery, request for second opinion before emergency decision. You're not asking for special treatment, you're asking for clarity. 3. During labor, ask one powerful question. When a doctor says heartbeat dropping, baby tired, liquor less, cervix stuck, emergency, sign quickly. Pause and ask, is this an emergency or is this a precaution? Real emergencies require immediate action. Precautionary suggestions should still give mothers choices. This question alone shifts the power dynamic. 4. Request to see the CTG fetal heart monitor. Strip. You don't have to interpret it. You only need to see it. If the heartbeat is stable, most hospitals will automatically become more cautious about pushing surgery because they know you're aware. If the heartbeat is truly dropping, doctors will show urgency with evidence. This protects both mother and baby. 5. Avoid very early admission. Many unnecessary C-sections happen because mothers are admitted too early, too anxious, too exhausted, or too uncomfortable. In many countries, hospitals admit early labor slows. Doctors call it failure to progress. C-section is recommended. Late admission reduces this chain reaction. As long as your water hasn't broken and contractions are spaced out, you can stay home longer, following your doctor's advice. 6. Ask for time, even in high-pressure hospitals. If your situation is not a real emergency, you can say, "Give me 30 minutes, let me walk, breathe, change position, and try again." Many women progress beautifully when given time. Hospitals sometimes panic for schedule reasons, not medical reasons, but mothers have the right to ask for a short break to allow the body to respond. 7. Consider a midwife or doula where available and regulated. Globally, countries with strong midwife systems, Netherlands, Sweden, UK, New Zealand, have the lowest unnecessary C-section rates in the world. Midwives provide emotional support, monitoring, non-medical pain management, labor guidance, advocacy inside the hospital. This dramatically reduces fear, which reduces surgery. 8. Understand the real C-section emergencies. True emergencies include confirmed fetal distress, cord prolapse, severe bleeding, placenta complications, stalled labor after active labor is fully established, dangerous maternal blood pressure, severe infection. If your doctor mentions any of these with evidence, surgery may genuinely be necessary and life-saving. Understanding real emergencies helps mothers identify fake emergencies created to rush decisions. 9. Involve your partner or family. One person must be the advocate. In global maternity research, the most protected mothers are the ones who have an informed companion who can ask, "Can we wait? Is this urgent? Can you explain the risk? Can we try another position? How is the heartbeat now?" Doctors usually push less when someone confident is present. 10. Remember that consent under pressure is not true consent. If a hospital creates panic, uses fear, or pressures you into signing, "Baby will die. Last chance? Quickly sign now. No time to think." These are high-pressure tactics, not medical explanations. In ethical medical practice, even in urgent cases, doctors must provide at least one sentence of clarity. Mothers everywhere, from Asia to Europe, deserve that clarity. 11. After the birth, request a full delivery summary. This includes reason for C-section, CTG readings, dilation progress, intervention timeline, anesthesia notes. This record protects future pregnancies. Many mothers discover that the emergency was not actually documented as one. 12. Most important, trust your body, not the pressure. Globally, millions of women safely deliver naturally every year. Your body is not weak, your body is not incapable, your body is designed for birth. Fear weakens labor, support strengthens it. You don't need to fight the hospital, you only need to stay informed. A mother who knows her rights is not difficult. A mother who asks questions is not disrespectful. A mother who wants clarity is not stubborn. She is simply doing what every mother is born to do: protect her child. Final message for all C-sections have saved millions of lives. They are one of modern medicine's greatest gifts. But when a life-saving procedure becomes a routine business model, when fear becomes a sales tool, when mothers across continents describe the same pressure, something is deeply wrong. The goal is not to shame C-sections, it is to restore balance, informed choice, and respect. Birth should not be decided by schedules, profits, or panic. It should be decided by truth, health, and the mother's voice. And the more we speak about it, across India, Asia, Africa, Europe, the Middle East, and the Americas, the more we protect the next generation of mothers and babies. If this video has been useful, share it with the mothers, sisters, wives, daughters, and families who truly care about a safe and informed maternity journey. Your one share may protect someone from an unnecessary surgery. And if you want more eye-opening, science-based, awareness-driven health content, make sure you subscribe to our channel. Together we can build a world where mothers are informed, respected, and empowered.